So our next session is, we've got another discussion panel. It's going to be on integrating communications with the EHR and the benefits of having a patient directory. And we have an insanely deep bench of expertise. It's going to take me like 15 minutes to read off everybody's credentials right here. But if you could just come up when I call up your name. So first of all, we have Dana Pico, who is our in-house clinical solutions specialist. She's a Team Steps master. Yeah, you can clap. She's a Team Steps master trainer. She's a clinical nurse educator. Come on up, Dana. Right. We've also got Emma Brandon, who's the Associate VP of Ambulatory Clinical Systems, Informatics, and Population Health. She has 40 years of experience. Come on up, Emma. And she spent 11 years in health IT as well. She's also joined by Alejandro Carvajal, who's a clinical systems manager at Mount Sinai in Miami Beach. With his 7 years of experience in health IT, and he leads IT teams in device integrations, radiology, and pharmacy, as well as a bunch of other things. And then we also have, our big winner today, Dr. Candy Friestad. Please come on up. Candy is the director of clinical informatics at Avera Health and also has 40 years of experience. So you guys, you should be well taken care of in this discussion. All right, take it away, guys.
Hi, everybody. For those of you, I'm Dana. I know a lot of you here. I'm happy to see you again. I'm sure you're all excited to see our next iteration of Volt with patient integration, right? Yes. So as Trey said this morning, over the last 10 years, we've done a really great job of building out a directory that makes a lot of sense to the clinicians, lots of layers, lots of ways to navigate it to make sure you can find the right person at the right time. So now in the next 10 years, we've got to start thinking about the core of what we do, which is the patient, right? We need to have that patient-centered directory so we can know exactly who that care team is at any given time within the ecosystem, so that communication is fast and furious, and we can go ahead and make sure we get to the right person at the right time, right? So what I think about when I think about directory integration and having that patient information, you want to think about how you're going to do it. You're going to leverage your EHR, right? We want to go ahead and leverage what you already have in place. We're going to use an HL7 interface. That's all I know about it. I'm a nurse. I will not talk tech. I will talk nursing all day with you. But we will do an HL7 interface and follow your ADT feed, right? So we'll pull that patient information in, and then we can also pull in as part of that care team. I know many of you, I'm looking at my friend Joanne from Cedars-Sinai. Patient identification is really scary, especially if you think about Cedars. I think TMZ stands outside there all the time and trying to catch people going in and out. We can hide that information. We don't have to display all those names for those people to see. We can make it very confidential for your patients. And the other thing that I really want to point out is what is going to be in your patient-centric directory is not going to be all the nuts and bolts of that patient information. It's going to give you key information to identify the right patient and the right care team at any given time. So if you think about it, what you really need is the name, the birth date, the MRN number, and the sex. So if you have two patients named Joe Smith, 117, 177, you really want to know the name and the birth date. You don't need all of the other information. That needs to remain in your EHR. So I always call them the peeping Toms, the people who want to try to get information about those VIPs or those celebrity people. They still have to go back to your EHR. We're not going to put diagnoses in there. We're not going to put health histories in there. We're just going to give you information to make it easy to know and identify who that patient is, where they are, and who their care team is taking care of them. Does that make sense? Because at East, I know I get a lot of patients. It's not going to be that much information. It's just enough to drive that communication to the right person at the right time. So as you see here, I'm going to go ahead and do a quick overview for those of you who have not seen a patient integration. Has anybody not seen what the patient integration looks like? Thank you. I'm going to refresh everybody else's memory and give it to you. So we're going to go over just a few slides, and then I'm going to hand it off to Alejandro and Emma, who's going to talk to you about the pre-deployment strategy and what they did at Mount Sinai. Then I'm going to hand it over to our innovator for the post-deployment and what she did and their team did post-deployment and some really amazing outcomes that they found after they implemented the patient integration. And then last, because you're all going to run back to your organizations, you're going to say, I have to upgrade, I have to integrate with patients. I'm going to bring Mark out here from product, you know, sweet little Mark. He's going to come up here and he's going to tell you what you're going to do when you go back to your organization to get this ball rolling and have it gone live by January 1st. right? That's what we're here for. So without further ado, I'm going to do a quick overview. As you see on the screen, I am in the intensive care unit. I can see some information about the intensive care unit. I have rooms. We have rooms available right now. And I know a lot of you who have not integrated with the patients, it doesn't give you enough context. We have patients that move from floor to floor, room to room all the time. If there's a leak in a room, they're going to move that patient. If their status changes, they're going to move that patient. So it only makes sense from not having just the patient, the room number, but have the actual patient demographics that are following your ADT. So as you see, you can see ICU. The first thing you see is the patient's name. Again, if you need to hide it because of they're a VIP, they're a celebrity, you can go ahead and hide that. We can do that for you. So that way you can keep that anonymity. Then once you go ahead and tap in it, you can actually see the care team. Now I know that little video is pretty quick, so for those of you who want to kind of refresh your memory, go see Kat and the team, and they can do a deeper dive and walk you through this whole interface. But moving on to another feature of having the patient integration, we know that it's really important for physicians to reach out to their care team at any given time and get the right nurse or the right respiratory therapist from their mobile devices. We know also that some EHRs do not allow that care team or treatment team assignment. We know Epic can do treatment teams, Allscripts can do care teams. There's other EMRs out there that don't have that function and feature. So within Volt, we can go ahead and give permissions to certain users or roles to assign themselves within Volt to a patient. If your EHR does not support that, which Candy's going to talk about that, they can go right into the Volt system because it's the ADT feed. They can assign themselves to that patient. So if I'm a provider, I'm a hospitalist, I get my new patient, I can go ahead and assign myself to that team, to that patient, and anywhere that patient moves, I'm going to stay with that patient. And you'll be able to see, as you see on the screen, at the top of my home screen, I'm going to have all of my patients listed. So I no longer have to stop at that kiosk at the door, type in my credentials, and get a printout. I can use my mobile device and know exactly where my patient is at any given time, and also find out who the care team is associated with my patient. It makes it quick and easy and efficient. And our VoltMe users can be at home, in their office, in their clinic, and they can reach out to the interior of the hospital and reach out to those nurses, respiratory, pharmacy, anybody they need to, right from their mobile device. We're going to stop all of those call stops, right? How many times do physicians call the unit, get delayed at the desk, can't get the nurse that they need because they're really busy? By the time they call them, it's 30, 45 minutes later, and that information needs to be fast and instantaneous. So VoltMe, that's really fast and efficient for them. So as you see, you can go ahead and see your patients. The big difference between a nurse and a physician, obviously, physicians move all throughout the hospital with their patients, right? Me as a nurse, NICU nurse, they're the best. They stay right there in the rooms. Nobody even liked that. Usually people like NICU nurses. They stay right with the patient on that unit, right? They are going to be room-centric. They're not going to be patient-centric. I do not want to go with that patient if it gets transferred to PICU. I want to stay in my NICU. I'm going to have at the top where it says my patients, it's going to say my rooms. Same thing holds true for anybody else in that realm. They can be your respiratory therapist, physical therapist. Anybody within the directory can go ahead and have their rooms listed right there at their disposal. And the last feature I want to kind of highlight for everybody is obviously your care team view. We want to go ahead and make it easy and fast and effective to go ahead and find exactly who you need. Again, like I said, if I am an internist in my office and I had my patient admitted over the weekend, I want to talk to that hospitalist about what went on with that patient over the weekend. I don't have to go into the EHR and try to dig in and find out who that doctor is. I can go right into Volt from VoltMe and find that physician, have a conversation with them, and see what happened with my patient over the weekend. Same thing holds true for, I always think about people who are not necessarily tied to the care team, but have to coordinate a lot of procedures or care. Think about your imaging services, right? Imaging services are trying to balance inpatient and outpatient procedures, and they need to go ahead and make sure that schedule is nice and tight because they don't want patients sitting in the ED a long time or to miss those outpatient scheduled times. This way now they can reach out directly to that nurse, find out what's going on with that patient because they know exactly the patient, the room, and the nurse caring. So they can go ahead and set up at those times, understand when would be the best time to bring that patient down for imaging, and communicate directly with the person providing that care. Makes sense? Makes you want to go home and do it? After these guys, you really are going to. So as I said, we're going to hand it over to Mount Sinai because they are going to talk about their pre-implementation strategy, what they did to get everybody ready. So I'm going to introduce Emma and Alejandro. You clap now.
Hi, good afternoon. My name's Emma Brandon, and I work at Mount Sinai Medical Center in Miami Beach. I have been there 7 years. I've been a nurse for over 40, and in healthcare IT for about 20 years now. And coming to Mount Sinai 7 years ago, probably about most of the 7 years, we've been trying to get Volt. So I finally got it, and we went live last week. So, Yep. So it's an exciting time for us at Mount Sinai, and we're really excited about all the innovations. Every single day, even yesterday I was at a meeting that they were trying to saying, well, we need the lab to have messenger and radiology so they can figure out what nurse has a phone for that critical value and what phone number they have. So there's great opportunities with this solution and the patient integration. But let me tell you a little bit about Mount Sinai. We were founded in 1949, and we are the largest independent private, non-for-profit hospital in South Florida. We're the largest employer in Miami Beach. We have 674 in-house beds, and we have 13 locations live with a 14th location and freestanding ET going live next month. We have a 7-story new tower being built. That's why Volt came along. And this year, we were recognized by IBM Watson for one of the top 100 hospitals in quality improvement. We're also HIMSS Stage 6 in both the hospital and in the ambulatory site. So what you have to start is with a vision. And our vision is to improve our response times for patient care. So patient satisfaction is probably the most important thing that everybody has to deal with right now because of value-based purchasing and our funding and all that. So having a solution like this improves that. We have patient alarms from our monitors. We'll have patient alerts for critical values, as well as improved communication with the other caregivers. So by implementing this, we're going to be able to assess the impact on our quality of care. Our goals initially are to decrease our response time to critical values, decrease our falls. We have integration already with Roll On Board and Volt with our bed exit alarms for Stryker, as well as posing alarms. We also want to decrease our medication errors by improving communication with our pharmacy and our providers. And we want to improve our patient satisfaction by improving our communication in general. So our project strategy, what we did first, once we signed this contract, is determine the phases. What do we need to go live first? Well, we decided to do a pilot first because it was really important for us to make sure it all worked. We started Roll On Board probably over a year ago, and we were live in 4 pilot units in the hospital with Roll On Board, and originally they had Cisco phones. Last week they got Volt, and they are in heaven, because if you compare Cisco phones to Volt, it's a whole different experience, so very positive initiative. We created committees with key leaders in the organization as their executive sponsors. If you don't get the support from your operations, you're always not going to do well. You've got to get them engaged, speaking, and involved, and that's the way that any project in healthcare IT anywhere is important. We planned a kickoff, and what was different with Volt, we made them be a part of our kickoff. So it was an IT kickoff with Volt. We both had sets of slides. We reviewed, we established the governance. We set the same message throughout the organization. What IT expected of all the leaders in this organization and our educators and our directors of nursing, we set that stage, not from just an IT platform, but also Volt. And they saw how it's going to function and saw how it's going to work for them. And we told them what meetings they were involved in, who are the key decision makers, and how things would be escalated. So the first thing, of course, you have to have your executive steering committee. The role of the executive steering committee is basically to understand what decisions are being made by your operations subcommittees, as well as making decisions that they can't make. So the final decisions that they're on the fence with this or that, this is the decision-making body. So we have our COO, our CIO, CMO, CNO. We have a huge project management office that they're very involved in a lot of the organization strategy. So they're involved, as well as IT project leadership. We have subcommittees. So, and the subcommittees meet approximately every 2 weeks, depending on what's going on. So especially for the first phase was on the med-surg unit, so we had acute, really acute care nursing involved mostly, but ICU is engaged and also respiratory. And that is led by our acute care CNO. And AVPs are there, directors, as well as educators. We have an ED committee where the AVP of the ED department, our ED physicians are engaged in that one. That's going to be very integrated. Managers, directors, again, educators. We had surgical services. Our VP of surgical services is there with her directors and educators. And then we have the physician experience. So our chief medical officer meets with informatics, which is myself and the director of informatics, identifying what, initially we have 22 physicians that have been, attending physicians that have been recruited for this pilot, and then we're going to roll it out to residents, which will be a different challenge. IT subcommittee, we meet weekly. We have the core project team that Volt, connects all get together and we plan and go through our project management and our issues. We also have the technical project team that separate with Volt, and they set everything up to make sure everything's working right. And we actually have our reporting team since the beginning. They had already created nurse call reports, so it's really important that the change that we made into Volt matched or was similar to the information they were receiving before about the nurse call. So they were a part of our testing to make sure everything worked correctly. So it's really important to engage your reporting team right away. And then we have IT integration, device integration team, and that's our internal team that focused on the implementation and support. I'm now going to hand it off to Alejandro Carvajal. And Alejandro was a project manager of this great implementation, and he's great to work with.
Thank you, Emma. All right. Thank you, everybody. One thing I need to mention before kind of moving forward with the slide set is that all the people that she just mentioned are my best friends. It's one key factor to make sure that the communication between all of those committees is tight, because of course the request from one committee could be easily a global setting that's going to affect the entire organization. So everybody needs to be working tightly and have good communications between the different committees. With that said, we did not go big bang. We pretty much phased our implementation. Our go live last week was phase 1, which was our 4 acute care pilot units that had their roll-in system for nurse call. And this way, when we went live, we already had the alarms in addition to the secure voice and text. Phase 2 is going to be our implementation of our new surgical tower, which you've seen in some of the pictures prior, which has our new OR, ICU, 3 acute care floors, as well as a new ED. And because we're going to have a brand new ED that the staff is moving, we added the phase 1B in order to introduce Volt to them first, in order to help using Volt as a communication tool to the transition from the current ED to the new facilities. And it will also make sure that's one less thing that's new to them as they're changing environments and not impacting the patient care. Our phase 3 is then going to be to expand our alarms with physiological monitoring with space labs. Phase 4 is going to be going back to the rest of our facility to ensure everybody is in the directory and communicating correctly to improve the patient care communication. And lastly, phase 5 is pretty much where we all are we're hearing from other presentations of expanding more alarms and alerts for different situations. like we've seen in previous presentations. So to talk a little bit about patient-centric design, where did we start? When we told our leaders, hey, we're going to introduce mobile communications to the hospital, in their mind, they already envisioned a device where they're going to see who's in the hospital, where they're located, who they are, and who's caring for that patient, so they can easily just tap and text and contact that patient, and easily find everybody that they need to. So we jumped into the patient-centric directory design using the Datica interface, HL7 interface, to ensure that we get all that information in. And then the next big question was going to be, well, we have the nurse call, and the assignments are currently done in the nurse call system. And one of the highlights would be that from Volt and many of the other vendors is that we have a lot of options. So of course, with these committees, we were able to kind of figure out what was the best option for our organization, and that was going to be pretty much taking advantage of different pieces. So we merged everything together where our clinicians are making their assignments in the nurse call system, because they like to have that one person assigning everybody to ensure that no patient is left behind. And then everybody's already doing their treatment team assignments in Epic, so we're pulling that in, so we're not adding any steps to their workflow, and the directory is pretty much populating itself. We, of course, going to have those exceptions. A good example is going to be like the lactation nurse consultant. They can manually assign themselves in Volt to make sure that they are still part and present in the patient-centric directory. So the result of that, as you can see, is just the merging of everything with Connexo and the middleware to make sure that everybody's getting their right alerts, as well as knowing who's who in the patient care. And that comes to the examples that Dana already shown, that we're able to get alarms, text, and the entire treatment team. So the things that we are super happy about is going to be the things that we're no longer going to be dealing with the implementation of Volt. And the things of the past is really going to be that the staff is no longer have to come in every shift and assign the extensions, have a log. Then the log usually gets copied and shared with other team members. And sometimes you need to go to different systems in order to know who's caring for the patient because it's not in that sheet. Or having people on hold because we don't know where that person is or how to reach them, and they need to be paged, and then they have to wait until they come to the court desk in order to take that call. So we have just gone live last week. We have nothing but a success story to share about it, and we're looking forward to completing the rest of the phases that I mentioned. Thank you.
Very nice. Okay, next we're going to talk to and hear from Candy, who's going to talk about post-deployment and some amazing workflows and outcomes that they have come to find at Avera.
The eyes are not what they used to be. I have been asked by about 2 or 3 different people here if I were going to make jokes when I come up here. And because of that, I'm going to talk about what Avera is first, and then you'll just have to hang on with me for the jokes. Okay, so what is Avera? Well, Avera is, we're in 8 states. We have 36 hospitals, and you can kind of see the numbers there. We're HIM stage 7, and we are just in the process, actually, we just submitted the paperwork for our 5th attestation for Magnet. And so I'm going to talk a little bit about Magnet and how we incorporate a lot of the technology that we have in Avera, as well as the specifics with the so what factor. And so we'll talk about that in a second. But I did want to show you what it looks like up in my neck of the woods before, let me go back. Okay, so the leaves are just starting to turn now. It was 52 degrees the night before I came to come back up here. I realize that there's everybody from across the country here, so it's kind of like, yeah, we got that too. But I would just say staying on top of the hotel here and that glorious warm breeze was just fabulous last night. So I'm looking forward to more of that tonight. But the one thing I wanted to point out is that this is a close-up of my old stepladder from that farm. I never really knew my real ladder.
Oh.
I can do it again, but I'm not gonna. So I know there's a fair amount of healthcare people, so I grabbed some of these from a healthcare perspective. So consider this your break, your joke break for just a minute. What happens if you get scared half to death twice? Oh man, probably should have had more coffee for this group. I checked into the Hokey Pokey clinic and turned myself around. All right, so let's go now. There's lots of techie people in the audience, so I'll do this, a couple of those non-healthcare related. I went to the Air and Space Museum, but there was nothing there. For those of you that are parents, I child-proofed my house, but the kids can still get in. Oh, okay, well, there's enough of that. This is a really stupid one. Like the other ones weren't. They're not going to make yardsticks any longer. Okay. I have a couple later ones and one political one, but I'll leave it at that for the moment. So, all right. One of the things that other people talked about making Volt come. I think you two talked about making Volt come to your kickoff, and I would see that that is the case for us as well. They're really embedded with us as we move forward across the platform. Our next go live for one of our facilities, we have, give or take, about 10 of our facilities are fully up either with Volt 1, Volt Messenger, or Volt Me. Our next facility is in Minnesota, and our go live date is the 22nd of January. Okay. And so several people have agreed to actually come up that direction, so I appreciate that. But one of the things, when we heard about the patient-centric directory, we decided we really wanted to explore this and go live with this, because if you think about it from a healthcare perspective, providers really think of patients as patients, and they follow those patients around the facility. Most other caregivers, especially nursing, think of patients as rooms. So I'm going to assign myself that room, and I have this particular room, and I'm going to have the next patient that's in that room, and the next patient that's in that room. And how can I handle that with Volt? One of the things that Mount Sinai talked about is the fact of how they do their assignments. We have done our assignments a couple different ways. We have Connexall as our middleware, so we started out with assignments there. Our EMR is not Epic. We have a Meditech EMR. I realize I'm the only person in the room with a Meditech EMR, but there really isn't a care provider platform in there. And because we're 24/7 hospitalists or laborists or surgicalist coverage, that particular person that admitted that patient may not necessarily be the hospitalist that's taking care of them this day. So we ended up using the teams and the roles and really integrated it with the patient-centric directory to be able to help us figure out who's got what patient from a provider perspective, as well as what is the care team that I'm working with right now. So when we went to Volt Alarm Destinations, or VADs, we decided to make our, at the request of our bedside staff, they said, I don't want to go to another computer to make my assignments. I really want to be able to do it from my phone. So we've incorporated our assignment piece directly from the phone. We have a surgical unit that's a 56-bed unit. This isn't our largest 500-bed facility. And if I am taking care of 5 or 6 patients, I may very well have 14 patients that I've taken care of because of the churn rate of those surgical patients. And so consequently, it was just difficult for them to make those assignments. But if I can do it right from my Volt phone, it just makes it a whole lot easier. So that's how we incorporated it when we set up the patient-centric directory. So teams, on the other hand, we started looking at our providers. Our hospitalists, for example, are in separate teams. They might be on a surgical floor or assisting an oncology unit or on a medical floor, cardiopulmonary area. And so those particular hospitalists then are in teams, and then we've allocated those team colors. We're running out of colors, actually. We're at teal now as opposed to like red, yellow, black, gold, silver. So we have those teams then allocated as well so that we can see who is it that I'm contacting if I'm that bedside caregiver, or if I'm a provider, who am I contacting? Regardless of the discipline, I need to find out which people are working with this particular patient. And basically, this is a great mechanism to be able to see. So you've got the patient that shows up in a patient-centric fashion or a room-centric fashion. If you just fall across the top, that is how it looks to our caregivers. So an anecdotal example is we had a physician that was discharging the patient. She really wanted to find out from the pharmacist, I'm working on this particular medication, and talking to the patient about this medication, and the pharmacist had the provider had a particular question about it, just looked on the Volt phone, saw what pharmacist, because we decentralized our pharmacy staff, which pharmacist was directly impacted with that care, and then was able to have a quick textual conversation that I really think would have in the past been figuring out, call Central Pharmacy, this pharmacist is here. You kind of get the idea of how that would have worked in the past. So from Meditech's perspective then, and I'll try to do this pretty quick, we integrated a lot. Trey, what's his name? Really sad. Trey really was very correct about us saying, look, we want this, 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 and this, so that our bedside caregivers can really have specific things come to their phone that make sense. So in addition to the ADT information that comes HL7-wise, and we also use Datica like Mount Sinai did, we also send all critical lab results. We are able to send orders, and one of those primary orders that I'm going to talk about in a minute is discharge orders. So the discharge order goes to the nurse, the resource nurse or the charge nurse that's working that unit, the case manager, the social worker, the pharmacy tech, and the physical therapist or occupational therapist, if appropriate. Did I say respiratory? Anyway, all that entire team gets the discharge order immediately when the order is written by the physician in the EMR. So that really does help us from a timing perspective. I'll talk about stats here in a second. And then if there are any particular respiratory or stat orders, those are coming directly to the respiratory therapist that's taking care of that patient group. Again, how we can use the patient-centric piece of it as well as the roles and the teams. And then room service requests, this is something we're going to be working on where we actually have a system where you can actually have those requests come to our food ambassadors, and those are assigned to every specific area within the hospital. We also are Rollin 4 and Rollin 5 throughout our enterprise. We have two specific hospitals that are Rollin 5 that have the integration of the pillow speaker. Now, someone asked whether or not the nurses wanted that or not. Same thing for us. That was just more of a, no, this is your responsibility to talk to those patients. And if the fact that you can do it on your Volt phone when you're not with that patient is really important to us. The other thing that we do with that particular Rollin 5 systems that we have in place is escalation. So on this particular pillow speaker, there are 4 buttons. One is for nurse, one is for water, one is for toilet, and one is for pain. And so 2 of those go directly to the nurse, but not to the patient care tech. In the other case, the other 2 go to the patient care tech, and then that person can escalate as appropriate. What most nurses tell me that makes the most sense is if it is pain, and I know that this patient is having their pain medication is due in, say, like 5-10 minutes, I can quick talk to them on the phone, let them know what's going on, as opposed to me having to go back and forth. And that has been a huge patient satisfier from our perspective. So when that alert happens, then we have the capability of then filtering that and escalating it appropriately, and then can clear it either from the room or from different mechanisms within the phone to be able to do that. Okay, so this is the so what factor. So while we were doing our magnet submission, the whole point of there is we need data and we need the so what. So what, you have all this technology. That's really cool, but so what? And so this is the so what part of that. Because we use this, and someone else said Volt is a verb, and I would say that that's definitely true at Avera. One of the things that we have to do is figure out how we can get our patients out in a more efficient manner from a discharge perspective. And then the other piece is that an empty bed is worth $167 an hour. So if you think about that from an economic perspective, it makes it very telling that if you have a bed sitting open for 5 days, that can be $20,000 from a bed day perspective. So our leadership was really challenged us to say, how can you use the technology that we have in place to make a difference in your turnaround times for discharge as well as your communication for discharge. So another couple of pieces of data that I pulled is that 4.3 million days are spent waiting for an inpatient bed, and that can be from an ER perspective, and this surprised me that in 16, 37,000 deaths were related to ED boarding. So when you look at those kind of compelling statistics, what is it that you can do to be able to affect those? So we implemented our system in our largest facility, that's 545 beds, in October of 2015, and then subsequently have gone to an additional 10 facilities, and then I have lost count in how many clinics we're up in mostly where the providers have Volt Me and the actual clinic staff have Volt Messenger utilized. One of the challenges then we have based on the statistics, and this is a benchmark that's in the US, is that the best way to affect that discharge is to have 50% of your patients out by 2 p.m. and try to get 25% out by 11. And even some of the smaller units that you have, you can really see that you could change that statistic by just one patient. So how do we effectively do that? That's one of the reasons we decided to move discharge orders to all the disciplines that we can. We also have a meds to bed program where our pharmacy technicians actually can bring the medications up to the patient so that it can ensue the discharge happening in a more frequent manner. And so statistically, you can see that we're doing okay. I just grabbed one unit's benchmark. We're doing okay really with the 50%. We're pretty close there. But on this particular unit, this is a 52-bed unit, our discharge by 11 needs some opportunity. So we're going to be working with Volt in the future, and this is your precursor of seeing the roadmap coming up here with the Phil and Alex show. So that hopefully we can see a few inroads with this based on some of how we use Volt. So then another so what factor. So what does that mean? So 2 years ago, I presented the 2014 to 16 data to look at what kind of difference we've made. So going through this quickly, we have 3 minutes. The very first line is average order to discharge time. So 3 hours and 22 minutes, and we've reduced that down to 2 hours and 57 minutes. The key benchmark in the US evidently is 2 hours. So we have 57 minutes to meet that criteria of getting the order out in 2 hours. Now, for those of you that are clinicians are probably going, how can we? How can we do that? And so it is a challenge that we have, that how can you make that and still do the appropriate education and make sure your patient is appropriate from a discharge perspective. So it's a challenge that we have. Hang on to that one for a minute. What the next two are time of day. So in other words, what is the average time of day an order gets placed, and what's an average time of day the patient leaves? And so we've kind of bounced around there from 16, 17, and 18, but we've kind of held the gains, and really the difference between 14 and those last 3 years is our Volt implementation throughout. So in other words, the order comes in average of 11:35, and then typically they're out of the computer or they're discharged at 14:25 time of day. But the one thing I want to point out is both with that top number, 2 hours and 57 minutes, and the times, is that if you see how much and this is just the one facility, this is our biggest 545-bed facility, notice how much those numbers have increased. And we're still holding that same time frame. And so, not that we've decreased it, although I think we still have a challenge for that, but we've kept the numbers up there, or we've increased our numbers of patients. We're just now building a $170 million outpatient clinic and orthopedic center. We'll be implementing Volt when we go in there. We're also building a chemical dependency unit, much like in cooperation with the Betty Ford and Heseltine foundations. And every single plan, every single construction meeting that I attend, the expectation that Volt is part of that, and that we include all of that integration within all those construction pieces. So The other piece that we've been challenged with from our Vera community is that we affect our referral patterns. In other words, if I'm going to refer somebody in this 8-state area, I really need to refer within our own footprint as opposed to have them go out to a competitor. So the challenge that we have this year is to try to get VoltMe in as many hands of our physician and provider community, and that is in the thousands. And so we are actively working on that. We want to make sure that all of our rural sites have Volt. And another challenge that we have, and then I'll give you an anecdote on that in a second. And then we have to work with our clinic connectivity, and so that piece not only is VoltMe, but it is also the Volt Messenger piece for our nurses and our clinical staff that is in those committees. And then we really are trying to push the roles and the teams and how we can effectively use that from an integrated perspective. I'll just tell you a really quick story on that. About 4 months ago now, we brought VoltMe to a physician committee for the hospital in one of the hospitals in Minnesota. I suppose there were about 35 physicians and other providers in the room. We brought them up on VoltMe. We had them text each other. We got the secure piece in, and my associate Andy Taylor, who is an informaticist, who is thanks for all the things you said nice about me on the video. Andy, I appreciate that. And so he is a rock star when it comes to Volt and all the technical pieces that go with that. We demonstrated it. We had our chief medical officer for all of Avera there, and he also supported it. That was a Thursday. The following Tuesday, I got a phone call, or it was actually Wednesday, but what happened on Tuesday is Ed, one of our ER docs in that hospital, called me to say, you know that Volt thing you did last Thursday? I said, yeah, and he goes, I think we saved a life there. So we had a patient that came in with a heart attack, and I didn't know it at the time. I put him on the monitor. I took a picture of that, saw that Mike Hibbard, who is a cardiologist, was actually in Volt, quickly sent him the picture of that along with the text, what do you think about this? Mike immediately texted me back, and he goes, call the helicopter now. That guy is actively infarcting, and brought him immediately to our heart hospital, and it had that kind of a effect to be able to save a life with Volt. So you hear all the statistics, but it's kind of nice to hear the stories too.
See, that's reason enough to go forward with patients, right? Saved a life. So our last little snippet is going to be with our sweet Mark Heddig, wherever here he comes.
Sweet Mark Heddig.
So he's going to talk to you about what you're going to do when you go back to get this ball rolling, right, my friend?
Absolutely.
There you go.
Thanks so much.
My pleasure.
You know, Candy, thanks so much for telling us about that. Avera's been doing room assignments for actually quite some time now, and it's proved extremely beneficial even without the patient's integration. But it really does build on top of it, and it's so exciting to hear about all the progress you guys have made. I think it was about almost exactly 1 year ago when I was in Sioux Falls for your patient's controlled release integration go live. And I remember I was actually in Andy's office. We flicked the switch, and I ran out to the unit that was demoing or trying out the patient's integration, and I found the first doctor I could find, asked her to pull out her Volt phone, and I showed her the new patient search option. And I said, well, what do you think about this? What would you do with this? Right, because you don't want to lead them. And she immediately goes, well, obviously that's where I search for the patient, and that's how I'll find the nurse. And then she proceeded to exactly show me how, as if she had been doing it forever, and teach me about the way that it works. And it was really, really exciting to see, obviously you can't teach a doctor. You're only telling them about things that they didn't know they knew. But it was so exciting to see how quickly, she picked up on it, and throughout that week that I was there, seeing it sort of spread, and it started slow, but eventually it did definitely pick up, and you started to see the providers assigning themselves in the Volt application. Extremely exciting stuff. So thanks for bringing that update to us. The next steps for you all to have that same exciting experience of being told by your users about things that they already know involves a couple things. One, your HL7 feed, your ADT feed being sent to Volt. We're extremely flexible with the types of messages that we can accept. We've definitely built the ADT engine to not require your team to do a whole bunch of special work to tailor your messages to us. It should work pretty much out of the box, and we've seen some pretty good success with that, not requiring any of your special teams to go and do a bunch of development work and things like that. Out of the box, working. We can do a lot of customization around VIP and confidential patients that Dana mentioned. So really exciting stuff. Hopefully, you send us a couple of sample messages and we should be able to say, yep, you're pretty good to go from an integration standpoint. Now, who here can say with confidence that their EHR treatment team is 100% accurate?
If you can, you win a prize.
Yeah. You win free Volt Enterprise license.
Oh! We're straight.
So that was a pretty safe offer because of all the customers I've spoken to, no one has been able to say that that's the case. So this is a really good use case for a nice carrot to start that process, right? Up until now, there hasn't been a really good reason to keep those EHR treatment teams up to date necessarily. So this is one really useful thing. If you are going to do the treatment team integration, right, it's a super useful carrot for providers and nurses to start to see, I log in on my VoltMe device, and I can see all of my patients there, and I can quickly find the nurse, the PCT, the respiratory therapist, the pharmacy team, right? So being able to quickly find all that information right there from the beginning is a huge thing that up until now just wasn't around. So we're really excited to be able to do that, and this is a really important piece for you to start that process in your hospital. The last thing I'll mention is that from a Volt perspective, the message must include the full treatment team in every message. It's not usually something that we've seen as a complication. Your Epic TS or EHR representative should be able to configure that for you. Doesn't take any custom development. It's a pretty simple configuration that you're likely already doing today. Now, we heard a couple of different use cases here. One where, for example, at Avera, they don't have treatment teams in their EHR, and they're relying on the Volt assignment piece from a provider's perspective. Whereas at
Mount Sinai.
Thank you. I was about to use the MSMC, which is how we type it. At Mount Sinai, they're doing some treatment team automation and some really exciting stuff there. But you don't have to do it all at once. It's not an all or nothing situation. We can do specific roles, teams, units, et cetera, where you can focus on, if you've got treatment teams for specific use cases that are already accurate, we can automate just that particular portion, let the demographic information flow in for those other units and locations, and then as you start to get those other workflows accurate, we can then begin to automate them. But it's not an all or nothing situation. So I would recommend focusing on the high impact units first, high impact workflows, teams, locations, get those going, automate there first, and then move from there. We're hearing a lot of really exciting success stories, like the one mentioned at Avera, getting the helicopter, and we think that you'll see the same success at your hospital.
Yay! Yay! So we are tight on time, so we need only one question. But don't worry, because we have breaks coming, and all of these lovely panelists are there at your disposal to ask more questions.
And the unsession.
Nathan, my favorite. I always rely on you. You are always my go-to. I know, you're a giver. So you can give us a question. Do I need a mic? Yes, you do. Where are our mics? Run, Kendall, run. She's coming.
So I know, Dana, I promised someone earlier I will try not to be that guy again this year, but I just can't help it. So I'm going to go with it anyway. And I am going to bundle two questions in one. But for the Mount Sinai team, I know you're in the honeymoon phase right now with Volt and ConnectSol, but what are steps you're taking, if any, for the care and nurturing of your deployment 2-3 years from now? So in other words, what's your operational support framework for these applications look like in terms of resourcing, and how do you plan to transition once you're post go live and implementation to an operational support team? And then second question for everyone, or maybe Mark, is that care team, is that bi-directional? Does that feed, is there any potential to update Epic or the EHR with that care team based on the assignment? Sure. So,
Do you guys want to go first?
Yep. So for answering your question, at the moment, yes, we're still in the honeymoon phase. Our focus is pretty much training and deployment so that we get the entire organization up with Volt. And we already have strategies in place that we're looking to roll out in order to get everybody trained, especially as we have some units that are live and some that are not, dealing with, like the example of those floats, to have quick e-learnings and refreshers that people can come and pick up. From the IT perspective, our organizations has a team dedicated for device integration, and Volt and ConnectSol and all these pieces fall under that team. So we're already prepared with some resources that are dedicated for this kinds of communications.
Plus, we've also trained the help desk on Volt to do some simple troubleshooting, and then if they can't answer it, then they call. Then the second tier is our clinical systems team, and that also does device integration. So we have a pretty solid team, and they do multiple support for after hours, especially.
Okay, Mark's going to wrap it up now for you.
I'll bring us home.
Bring us home.
All right. So the answer is it's not bidirectional today. We really believe that the EHR should be the
true source.
Exactly, the source of truth. And we would encourage you from a patient's perspective to put those assignments in there and let all of the other systems receive that downstream.
So you guys can ask them all you want the rest of the evening. If you after dark, they are here to help you. But thank you to everybody that participated on this.